Hello, and welcome to today's live webinar, Optimizing Reimbursements for Diagnostic MSK Exams, Ultrasound-Guided Interventions, and Surgery. We're excited to welcome back Dr. Alan Hirohara, who's board certified in both orthopedic surgery and sports medicine. And shortly, we'll also be introducing you to Dr. Alberto Pinheiro, who's board certified in physical medicine and rehabilitation. We're excited to welcome our entire American audience today for an important discussion on how to optimize reimbursements with point-of-care ultrasound. Ultrasound is a time and cost-efficient imaging modality that's fast becoming the standard of care across orthopedic surgery, sports medicine, and interventional pain management. Studies have shown over and over again that using ultrasound to guide procedures significantly improves patient outcomes and satisfaction. It's a win-win for the patient and physician, with both medical and economic advantages over other modalities. Using ultrasound in your office, operating room, and during athletic events not only helps to deliver better patient outcomes, but it also increases your revenues. But since accurate coding can be tricky and is essential to optimizing reimbursements, we'll be inviting Dr. Hirohara and Pinheiro following our introduction to share their guidance for the best reimbursement outcomes for you and your patients. Let me first introduce you to your host for today's webinar. Dr. Frankel is trained in emergency medicine in California. A passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He practices in a busy academic teaching hospital in Vancouver as an emergency physician and serves as chairman of our medical advisory board. Dr. Frankel, hello again.
Thanks, Janez. It's good to be here. This topic is near and dear to my heart. To set the stage for today's conversation, we did a bit of a literature review, and I just wanted to jump in a couple review articles to set up our webinar speakers. The first was a recent review from Sports Medicine that I really love because it summarizes how I honestly feel that whenever we touch patients, the ultrasound seems to make our job better. Across the spectrum of practice, ultrasound improves diagnostic sensitivity and specificity, reduces unnecessary radiation exposure to our patients, lowers the cost, and decreases the time to diagnosis without increasing adverse events. It just makes us better doctors. And specifically, from one instance I wanted to highlight of implementing an ultrasound-based injection clinic that was done. This is a 3-year analysis that was put out of a group that set up a specific focus ultrasound injection clinic. They found some really interesting findings that our speaker is going to talk to further, that it not only increased clinic throughput, but it really maximized services that they could render in a single patient visit. It improved the perceived quality of the patient encounter, which you'll hear over and over again from our webinar speakers today. It improved the clinical practice of their mid-level providers too, offloading the surgical specialists that worked in the clinic, and it improved RVUs above and beyond their initial investment after just a single year. And this was based on traditional carts, which is going to even change the game as we go further into handheld devices. So to take us further into the discussion, I'm going to set up our guest speakers here. Dr. Alan Hirohara, we're really welcome to have back, who's board certified in orthopedic surgery and orthopedic sports medicine, specializing in arthroscopic shoulder surgery and sports medicine. He runs a busy private practice in Sacramento. Dr. Hirohara speaks and teaches nationally and internationally with published research on arthroscopic shoulder and knee surgery, orthobiologics, and the use of ultrasound. He was recently appointed to the NCAA Committee on Competitive Safeguards and Medical Aspects of Sports, and is currently involved with the Health and Safety Committee for the Big Sky Conferences. He's the medical director and team physician for California State University, Sacramento Athletics, and head team physician for the Sacramento River Cats. And he's been the team physician for the NCAA Championships and Olympic Trials in Sacramento since 2001. And welcoming for his first webinar with us, Dr. Alberto Pinheiro, who is board certified in physical medicine and rehabilitation with a subspecialty certification in sports medicine. He's the founder of SAC Regenerative Orthopedics, where he practices also out of Sacramento in California. He serves as core faculty for the UC Davis PM&R Sports Medicine Fellowship. He's regarded one of the experts in orthobiologics and musculoskeletal ultrasound in his field, having published on several respective topics. He's also presented his research in interventional orthopedic techniques at top orthopedic and sports medicine conferences. He's highly involved in the sports community as well in Sacramento, serving as team physician for Sacramento State University, the Sacramento River Cats, and the Sacramento Republic FC. Doctors Hirohara and Pinheiro, I'm going to hand it over to you.
Thanks very much, Oren. Thanks, Janez. Really a pleasure to be here. Along with Alberto and I, we've been working together for many years, and we're going to be talking today about optimizing reimbursement for diagnostic MSK exams, ultrasound-guided interventions, and surgery. Here are my disclosures and Alberto's disclosures. But we're going to start first talking about ultrasound accuracy, because that's kind of where it all begins. And there have been a lot of publications at this point, as Oren said, that injection accuracy, unfortunately, done blindly, is just not where it should be. And realistically, if we think about it, why should we miss? If we know where we're going, if we can see where we're going, we shouldn't miss at all. But yet, it's pretty clear that in many, many studies on the knee, for example, that the miss rate is easily in the 20 to 30% range, which to me is just not acceptable because you're trying to get into the joint. What's also interesting is how people say they do it. Traditionally, we're taught to use basically arthroscopic portals, either an anterior medial or an anterolateral portal. And the problem is that if you look at an MRI, you'll see very clearly that white spot is what you're trying to hit. And that's actually turns out not easy to do. Because if you look at it, it turns out that that spot, even with an effusion, is actually quite far away. Measured on this MRI, that's 4 centimeters away. Well, guess what? Most people use traditionally a 1.5-inch needle, a standard small needle, and you're not going to get to the joint. That's part of the problem. And realistically, why should it be painful? Because if you think about it, the nerves is where we feel things, right? But in the space, in the joint space, there are no nerves. There's nothing to feel. So if you're in the joint space, you should never have pain. The patient shouldn't have pain when you're injecting. And that's kind of the key point. And that's kind of how I realized why I needed ultrasound, because I realized once I started using ultrasound and no one was having pain, it made me understand if they had pain, I was missing. And so here's the thing. What could you hit? Well, guess what? You could hit the skin, the subcutaneous fat, Hoffa's fat pad. You could hit, of course, the cruciates. You could hit the condyle and the cartilage. You can also hit, unfortunately, that space, maybe. And as we've seen, not often enough. But there's an alternative. And the alternative is doing this suprapatellar lateral approach in plane. And frankly, even if there's no effusion, you can still see the plane very well under ultrasound and reliably hit it. And so for me, this is a no-brainer. This is about patient care. And I've tried doing this, the traditional method, using ultrasound. Alberto, what do you think? I mean, have you tried going in the front with ultrasound? I haven't been successful.
Yeah, I have tried that, and I don't think you get as good as visualization as doing the suprapatellar lateral approach, where you can keep the needle in visualization the whole time, see your fluid go into the knee joint. And personally, my customer or patient experience has improved quite a bit when I went to ultrasound because the pain really, really improved from these injections.
Yeah, I was telling you, I had 3 patients just today in my clinic tell me that they would not let anyone else do injections and they say these words, because I don't miss. It's funny, they use those words. It was really interesting. They didn't talk about ultrasound. They just the fact that I don't miss. But here's the thing. So when I'm doing these injections, I kind of set them up on the table, put a bump under their leg. And really, using the ultrasound, you can identify the structures, the quad tendon, the joint space, the fat pad, the trochlear bone. And really, what's really good is that you can pre-plan. So we can see that this whole entire image is 3.7 centimeters. So we know that I want to go down from my probe 1.5 centimeters approximately, and coming flat in, I should hit the spot. And as we run the video, you can see that there's a needle right where I want it, gets right to that knee joint, and then basically, boom. And if it's going to kind of create a bubble, then that might, of course, indicate we're in soft tissue. But once it starts to flow and you're putting enough in there, you can know that it's flowing within the joint itself.
I call this approach the suprapatellar. This is like the gateway drug for ultrasound-guided injections. Like, this is a procedure we all learned in medical school. We normalized the pain associated with missing, scraping, and the screams of our patients. And it was just told to us that that was okay and part of the procedure. But, and this is a joint we all do so much. And you go to ultrasound, it becomes this painless thing. And I think for clinicians I've taught and worked with, it opens their eyes to what else is possible even beyond the knee. This is the one we're supposed to be really good at, and we're not. And then there's all these other joints too that we all already know we're not good at. So this opens it up.
And what's interesting, Oren, is that I've told you before, you're in the ER, I'm in surgery. My patients aren't supposed to scream. Yours are. So I'm not used to that. So that's not good for me. I'm like, that's not good. So, and the thing is, you're absolutely right. 100% correct. It's so true. And even if there's even if there's no effusion, honestly, you can still hit it. So let's run this video. So in this video, it's showing you exactly what I was telling you. So I'm able to come in, see that I need to come up over the condyle. My needle's coming in over and through that fat pad, but then I'm going to angle down. So if I'd continued to go straight, I would have hit that tendon. But I'm able to go down under the tendon, down to the joint region. And as I inject, you see that it's not creating a bubble. That means that the fluid is flowing into the joint. I'm not in some soft tissue. And so there's no way that I could have hit that spot and gotten there without ultrasound. I would have for sure missed on this one. So unfortunately, shoulders are the same though. It's no difference. And so we see about a 30% miss rate, even on fellowship trained shoulder surgeons, they can miss quite often. And so even if you think you can ride under the bone, sometimes that unfortunate, supraspinatus tendon muscle can actually ride up and be high. So you might get in the muscle, not into the space itself. And it's really clear that on randomized cohorts, blind injections, unfortunately, are just never as good as ultrasound guided. And I think I blame personally Netter, because when I learned anatomy, I don't know about you guys, but I'm old and I learned on the Netter images, and that's a balloon. And I'm like, that's not what a bursa is. A bursa is not a balloon. It's a potential space. And you can see on the ultrasound there that the bursa is under that hyperechoic, subbursal fat, that suprabursal fat, that area, subdeltoid fat. That's where you need to hit, under that spot. And if you don't go there, because everyone seems to think that the bursa is above that white line. It's not, it's below it. That's where you have to be, but it's not always obvious. And that's the problem. So you want to set these people up with your hand on the hip, using the plane between the contralateral shoulder and ipsilateral hip for your probe. And you can see here very clearly, you see the fat, the deltoid muscle, the subdeltoid fat. As I said to you, that kind of hyperechoic line, the subacromial space itself, the supraspinatus tendon, and of course tuberosity. And of course, at this point, we can pre-plan, come in very clearly, and be able to see our needle the whole time, just as Alberto said. He's absolutely right. And then make sure you're not accidentally catching a piece of bursa or a piece of deltoid or a piece of muscle, and that it flows nice and evenly. Any other thoughts, Alberto, about any technique tips?
I think to your point, one is making sure that you see the nice flow because you're injecting into a space. There shouldn't be any accumulation. And also getting a little bit of feedback from your patient, right? It should feel maybe some pressure, a little bit of pain. But if you really start to see them jump, it means you're not in the bursa. You might be getting into the tendon. And also pay attention to kind of how much resistance you're getting on your plunger. It should be nice and easy where it flows. You almost feel the loss of resistance that goes in. So I think it's a great case example.
I think that's great. Yeah, I do very similar. I'll start a little puff and I'll ask the patient flat away, how'd that feel? Did it hurt? And if they say no, keep going. And if they say, oh no, it's starting to hurt, maybe I'm in the wrong spot. I totally agree, Alberto. That's a great talk. Yeah. And here unfortunately is a bursitis, right? So you can see very clearly that black area, that's clearly bursitis. So obviously getting that space is easy. And you can see how, what Alberto said, how it flows medially. It's not accumulating as a bubble, so that you're in the correct spot. So Alberto, why don't you talk us through a little bit of orthobiologics? Why is this near and dear to our heart so much?
Well, it's a good introduction there. I think orthobiologics, in the context on when to use them compared to corticosteroids, is a really good discussion to have, right? And I think that everybody has to know what the goal of the injection is, right? What is it that you're trying to accomplish with a steroid or with an orthobiologic? And also understanding what risk each one of them will have. And then how can we use ultrasound to mitigate some of those risks? So if we look at cortisone, it can soften or damage cartilage. It can weaken or rupture tendons. This is where I think ultrasound can be very important because you don't want to inject the cortisone into the tendon. You want to make sure you're precisely in the tendon sheath, and that will reduce the risk of the tendon tearing. It won't eliminate it, but it'll definitely reduce it by quite a bit. Also, if we keep going with some of the risk, looking at fat pad atrophy, right? With ultrasound, you can very precisely stay away from fat pads and make sure you're in the correct space, further reducing that risk. And there's some of these systemic risks that maybe we can't avoid with ultrasound, but I think if you're going to use cortisone, which I still do, there are life events that people go through. They need a quick pain injection, something to reduce inflammation. Hey, we can do it, but maybe use ultrasound to mitigate some of the risk. Or we can look at orthobiologics. One of the orthobiologics we like to use quite a bit is PRP, platelet-rich plasma, and this has actually been around for a lot longer than people think. And Al and I were talking about this yesterday about how long it's actually been. Look at the first described cases in 1969. even using open heart surgery in 87. And it was FDA approved in the US in 1999. Now, it's worth noting that that was for the use with bone grafting. So the uses that we have for PRP are off-label, but very much so able to use it in that manner. And there is basic science research that shows you that it's different than cortisone, right? You're not just mitigating pain with inflammation and then getting a bunch of side effects. This is going to do it in a much more natural way. So PRP, it's going to augment proliferation of tenocytes, osteoblasts, and myocytes, also reduces inflammation and pain. In joints, it can actually augment hyaluronic acid secretion and augmenting cell migration and proliferation. So basically, platelets go in there, they release growth factors and cytokines and activate the body's healing response. And right now, we actually have a lot of good level 1 evidence. These are just some studies in arthritis. PRP been shown to be superior to hyaluronic acid and to placebo. Also, there's level 1 evidence for its use in tendinopathy as well. We can certainly have a deeper discussion about what PRP and what concentrations to use, but there is data to support the use in both of them. So let's look at how ultrasound can be very synergistic with the use of biologics. And this is a very famous Achilles tendon by one Alan Hirahara. Alan came to me, he's like, hey, man, I've really been having a lot of this Achilles pain. We actually were able to scan his Achilles right in between patients very quickly and efficiently. And if you show the next picture, you can see what normal should look like, right? You see this nice Achilles tendon, hyperechoic signal, nice collagen fibers that measures 3 millimeters. His is about 6 millimeters with a lot of hypoechoic signal or edema within the tendon with some interstitial tearing. So
and you should let them know that actually, you should let them know that actually the normal is my other side. That's actually my other side. So correct. It's not that I just have massive tendons. Okay, Alberto, don't give them that sense. All right.
Fair enough. This is Dr. Alan Hirahara's normal. So we used ultrasound to diagnose the problem. Now we're going to use ultrasound to guide the therapeutic. So as you can see here, we're injecting intratendinously into the lesion with PRP. Note that this is July 18th. We can now follow this lesion week to week, day to day, month to month with ultrasound very efficiently. And you can see just in 6 weeks how much interval healing actually happened. You can see the tendon thickness is down, that hypoechoic signal is reduced significantly. And Alan, you were feeling pretty good by then?
Yeah, it's actually really good by then. In fact, I was off crutches at that point, whereas before I couldn't even walk without crutches. And you can see that really I was within 7 millimeters differential between my normal side. And, so it's hard to make it up when it's yourself, and so This is something that there's no doubt that this was needed and it does work. And there's no way I was going to let anyone put cortisone in my tendon or even near my tendon, especially when it's so superficial near the skin. So this is something that only PRP can do, but really it's not just PRP, it's PRP directed very specifically, which you can't do with an MRI, an X-ray, fluoroscopy, or CT scan. Only ultrasound can do this. So that's the only reason why I let Alberto touch me, even though it hurt like hell.
Yeah, you like the pain. Moving on here, I want to show a different example of how to use ultrasound. Talked about diagnosing, intervening, and then following up. But what about using ultrasound to determine what biologic to use? One of our experiences using patellar tendon, we noted that PRP worked, but maybe in some cases wasn't good enough. So we started to use bone marrow concentrate, and then we started to notice that, hey, our results are really getting better here. So we started to compare our outcomes. We had 33 PRP patients, 21 bone marrow patients. And what you can see on this next slide is on this yellow line is that PRP patients did get better. But after they returned to activity, a lot of their symptoms came back and they never fully were asymptomatic. As opposed to the bone marrow group, you can see that it took longer to heal, but it did heal much more efficiently and it lasted for 1 to 2 years. So then we started to ask, well, why is that? And what can we see on ultrasound that could be correlated? And what we determined that the outcome was based on the cross-sectional size of the defect, with this 0.5 centimeter square being kind of like the critical size. Anything smaller, we think, okay, PRP should be fine. Anything bigger, hey, we're probably going to go with bone marrow. So again, now we're using ultrasound to also help us determine what type of biologic to use. These are some of our results. So this, you can see proximal patellar tendon defect. We chose to do bone marrow concentrate for, which you can see again under direct ultrasound visualization. You can go right into the defect itself and make sure you cover the whole thing. So very efficient. And again, this is another beauty of ultrasound. Like I was mentioning, we were able to follow this patient week to week, month to month, very efficiently, and not having to get MRIs. And we're able to see subsequent healing from pre-injection, 4 months and 8 months. And Alan, I think you actually followed this patient a little more frequently, right?
Yeah, actually, this was my patient, and actually he was a basketball player. And what was interesting, he actually had bilateral patellar tendinopathies, but his other side was not as bad. So we actually PRP'd the other side. But what's interesting is that he was, had collegiate potential. So he was coming back like probably every 3 to 4 weeks going, hey, can you ultrasound me? Can you ultrasound me? Can you ultrasound me? And what was ironic is that this side did so well that by this point, he was begging me to do the same thing on the other side because the other side hadn't quite gotten as good. It was better, but not as good as this side. And it was clear when we looked at the ultrasounds that, yeah, the bone marrow for him, because the lesions were just too large.
Agree. And it would have been very challenging to follow this patient like this, MRI after MRI after MRI. Mm-hmm. So again, showing that. Well, I do want to bring up quickly biologic harvest. Alan, I know that we've talked about this. Sometimes some patients are hard to get their blood, right? So what can we do?
Well, and I do think this is really important to have all your options. I mean, there are in the ORs, they use the vein finders, but we have an ultrasound. So why do I want to buy another instrument? So, I just use it. And it's just so easy to grab it and do a quick check. So I think for phlebotomy, it's wonderful. And Alberto, I think you use it on some of the other things because we did a study on bone marrow aspiration, because when I asked you to go research and find the best bone marrow aspiration method, you came back and go, oh, there's nothing published.
That's right.
Oh, and so we had to basically make up our own. And so what we did was we did this analysis. And Alberto, I'll let you go ahead and take it from there.
Yeah. So that was really the point. One is we wanted to figure out what their ideal angles were to aspirate the bone marrow, but also we wanted to make sure that we incorporated ultrasound because we knew that with ultrasound we could find our landmarks. We could potentially guide the trocar right to the periosteum. Obviously, you wouldn't see it once you're in. But it will get you right to the point and also make sure that you miss the different structures. So we looked at various MRI analysis of the pelvis and basically came up with the ideal angles on where and how to get to your spot. And right now we can do it either directly under ultrasound guidance where you're going long axis the whole way, or ultrasound assisted where you just mark where your PSIS is at and then drop right into it.
Yeah, it really depends on the person. Because if you have someone who's really thin and you can really feel it, well, that's no problem. Because what we found out was you have to enter the PSIS at the most medial aspect. You can't be in the center, you can't be lateral because you have to come in at a 26-degree angle. And we found this across men and women. It wasn't just for one sex. And it was very consistent that if you were to come down straight or miss your angle, you had at maximum 3 centimeters till the opposing cortex. But if you came in at the proper position and the proper angle, you actually can get up to 7 centimeters of clean throw without hitting an opposing cortex. And that means you're going to improve your bone marrow aspiration technique and your bone marrow stem cell concentration. So it was pretty much a no-brainer that this had to be done under ultrasound because you had to make sure that your entry was just right.
Yep, absolutely. And I think lastly here, I think, really trying to look at the synergy between orthobiologics and ultrasound. We've diagnosed the problem with ultrasound. We've intervened. Now we're choosing to use an orthobiologic by what type of lesion we're seeing. And now we're actually going to use ultrasound to do the harvest. So it made perfect sense to me. If you're going to use adipose, especially if you're not used to doing lipoaspirations, grab the ultrasound out, create essentially your boundaries, make sure you're able to identify where the peritoneum is at, make sure you can identify where the muscle's at so you're not scraping it and creating more post-procedural pain. And I think you really make the procedure so much more comfortable for yourself and for the patient by using ultrasound. So this is a technique we came up with, and we still use it to this day just to make sure we're very efficient with our lipoaspiration.
But Alberto, I think we came to talk about billing. So I think you have to at least kind of mention that somewhere in this. Okay.
We have to.
All right. So let's kind of go into that now.
Sure.
So let's take it away. Ground rules.
All right, ground rules. So rule number one, we are not attorneys or legal or billing experts, but we do have a lot of experience doing billing for ultrasound. Also, understand that these rules and fee schedules may vary from state to state and between commercial plans. And lastly, just believe in the science. Always do what's best for the patient, regardless of what you're going to get reimbursed.
That's great. So, Alberto, why did we break up the codes? Because we did. We kind of broke them up. What was the purpose of this?
Well, I think it was really to identify the difference between doing a diagnostic evaluation, right, and an interventional use of ultrasound, and also to try to differentiate between other types of ultrasound or ultrasound modalities that, for instance, a physical therapist will use. So this is why for us, we really just tried to break down diagnostic and interventional CPTs.
So we're going to kind of go over kind of like what the reimbursements are for these things and how to actually get reimbursement, how to bill for them based on what you're doing. So what I did was I went to the cms.gov website, and they have a physician fee schedule search, and I encourage you to go yourself. Go look. And I've put the link at the bottom of the slide. And this is data that's updated since 4/1/22. So this is up to date as best I could find it. So if you bill a 76881 complete exam, that means you did a complete evaluation of the entire shoulder, say, everything, supraspinatus, subscap, infraspinatus, biceps, AC, everything, short and long axis. You bill it. The 2022 Medicare national average global payment is around $60. If you do a limited exam, 76882, and bill that one, and limited could be anything. You could just look at the supraspinatus and long axis and you're done. That's a limited, okay? There's no set amount you have to or have not to do. You're gonna get about $57. And of course, there's 76942. Now this is an important code, 76942. Ultrasound guidance for needle placement, imaging supervision, interpretation, you're going to get $59. Remember this code. We're going to come back to this a lot, 76942. Now let's move on. There are codes, though, for actual injections, like 20604, 20606, and 20611. Now, I use these mostly. This is for small joint, intermediate joint, and major joints. And the average global payment is $84, $91, and $102 for those codes, okay? The key in this, though, is that you cannot use the 76942 I just told you about, because these include ultrasound guidance. And that's a key difference. These include ultrasound guidance. So you cannot use 76942 with these codes in addition. That's separate. These are their own. Now, you might say, well, wait a minute. Aren't there codes for without? Yes, there are. So 20604, the corresponding code 20600, those are the two codes for small joint. And the differential is $84 payment with ultrasound, $54 a payment without ultrasound. And that's kind of the key point, is if you look at these, looking at 4, 6, and 11, you can see the difference. That roughly there's about a 35% increase of payment with ultrasound. So let's just talk about this. Let's just look at the breakdown. So let's do the math. Okay, assumptions. 10 injections per week, 40 injections per month, 480 injections per year. Let's just say average. You put in whatever number you want. Let's just make an assumption. Let's make an assumption you're going to make about $30 to $40 more per injection with ultrasound. So at the low end, you're going to make about $15,000 a year more, and at the high end, $19,000. That's not insignificant. And as you heard Oren say,
it's the system incentivizing you, it seems like, to do the right thing for the patient.
Correct. And Oren, you said this, right? You said you started us off this way. You said there's clearly a way that it will pay for itself in the first year, right? That's what that paper said. This is why. Yeah. And obviously, the more you do, the more you're going to get back to reimburse yourself. So this is very clear that you will definitely make more money quickly. And as Oren said, and he's absolutely right, as we start getting handheld devices, which are less expensive and more usable by more people, my gosh, this is just going to blow up.
Would you say it's worth addressing too? I was going to just jump in. People who are new to ultrasound. This is us three who we just use it all the time, and no needle basically goes in a patient without the ultrasound at this point for us. But for people who are new to it, there's an opportunity cost that we should acknowledge of learning how to use it, getting good. And like these kinds of incentives, I think kind of build in and help support that opportunity cost too for education and making sure people feel comfortable, taking the time to learn, like it's going to pay off in the end. And it's worth learning and getting good at it.
I thoroughly agree. And when people always ask me, well, which one should I get? Get whatever you're comfortable doing, you're paying for and seeing. You're going to get reimbursed. You're going to make your money back. And then once you're in and you like it, then you can go buy a bigger, better one that you like. And then eventually you'll get that reimbursed as well.
The one last comment I wanted to make is you're also going to generate more traffic through your clinic once people know that you're using ultrasound and the other guy is not, right?
Yeah.
And people will come to you just because you are the ultrasound guy. So that's another source of revenue that will get generated. And guess what? You're providing better care. So it's a win-win.
Yeah, what's really funny, actually, you say that, Alberto, is that, as a surgeon, I do not want to be in my clinic doing injections. Sorry, that's not my job. And I try to offload a bunch of people onto you as, the injection guy. You know what their first question is? Well, does he do ultrasound? Yes, he does.
Yes, he does.
He does. It's okay.
It's okay.
Yeah. No, it's true, though, but you're absolutely right, 100%. I mean, people actually do realize it. So, Alberto, what do you think about these codes?
Well, these are other injections. So basically non-joint or not bursa injections. So those bundled codes were primarily for joint injections. These are for other things. For instance, carpal tunnel, or if you're going to do a trigger point injection, or if you're going to do a tendon sheath. So in this setting, you're going to actually report two different codes. You're going to report, number one, the actual injection code that you did. And number two, now you can add the 76942 for ultrasound guided, which will add about $59.52 per encounter currently.
Right. But what's a global fee? So I've said this now a couple times. What's a global fee, Alberto?
Well, global fee is basically if you own the equipment and you're getting the fee for everything, right? You're getting the fee for performing the service as well as using the equipment and the cost of the equipment. You're basically getting paid for the whole thing.
And I think that's a key point because now we're going to show you how it splits out and how under different circumstances, you might need to add a modifier for whatever situation you're in. Like this is, if you go to the cms.gov, and I've actually done a screenshot for you that I actually looked at this. So I took 76881, and as I told you, you get paid $60.22, okay? Now, let's say you're in the hospital and you don't own the equipment. Can you get the global fee? You cannot. That is illegal. That's illegal. You can only get the professional component interpretation only for the procedure. Okay. And the way you do that is you have to tack on a -26 modifier, and now you get paid $30, $30.80. And this is all, as I shown you, on the CMS website. So it's all transparent about what you'll get, and you can go look it up yourself. But the point is that you do have to bill correctly. That's what's critical in this, and understand the rules. Now, Alberto, what if it's in the office?
Well, in the office, you want to notify that you're basically doing a significant or separately identifiable service to your E&M. So your E&M will be your consult, a reviewing of images, physical exam, coming up with the treatment plan. Now you're also going to do a diagnostic or interventional ultrasound use. That's when you have to use this 25 modifier to indicate that, hey, I am billing for a separate service on the same day as I did an E&M visit. But you have to be a little bit careful here. It doesn't mean that you just tack on a 25 to every visit. You want to make sure that you dictate why you looked at ultrasound and have some justification about doing it. And, just be judicious about the use of ultrasound.
Yeah, but Medicare covers it, right? I mean, that's always been a big question people ask me, like, does Medicare cover this? Do they agree with ultrasound?
Yes, but I think we're going to go into a little bit more detail as to how.
Right. So the key here is that ultrasound is absolutely approved for use with Medicare, but there are categories in which they agree or disagree. So category 1, you're all good. Category 2, they don't. And there's actually only one thing listed in category 2 currently. But they also recognize the fact that this is a rapidly evolving area. And so, they're very open to hearing and reviewing before payment to make sure that it's appropriate for use. And as long as you really submit a medical justification of why you did it, for the most part, I've never seen this looked at myself. Have you, Alberto?
I have not. Thankfully, we've kept good documentation. I think we do it for the right people. I have not had an issue getting reimbursed by Medicare.
So this is another question I get asked all the time. Does insurance pay for this, or do I have to do a cash pay? Now, there's two different things, right? There's ultrasound and there's biologics. So let's kind of focus more on kind of the combination of the two, right? So Alberto, what's the key point?
Well, what you have right on the screen there, are you a part of the insurance network, yes or no? And that will determine everything. If no, let's say you are not enrolled or you're not a part of the insurance network, then you are able to charge cash for that patient that has the insurance. If yes, then you have to attempt to get a prior authorization. And if that prior authorization gets denied, then you can actually charge cash for that patient. If denied, then you, and in that token, you still want to look at doing an ABN. It's an advanced beneficiary of non-coverage, or notice, if you will. You really want to do this, I think, primarily with the Medicare patients, but I think you could look at doing it with all the patients that are going to charge cash with. And as it reads here, basically what it is if your doctor, other healthcare provider thinks Medicare probably won't pay for those items or services you got, then you can sign this ABN and then decide what to do with the actual claim.
And that is exactly why we recommend that if you're part of any insurance network, and even if you're pretty sure they're not going to pay it, because historically they haven't, you never know when they change. Because actually, we've been starting to see some insurances starting to actually authorize them and pay on them. So don't just assume. Keep up the process of being correct and on it and doing the right thing, so that if ever you got audited, you say, "Hey, look, we show you we do this correctly." Okay, it's if something is amiss, it's not our fault. We're trying to do the right thing.
Correct.
So let's do some facts. Let's do some FAQs real quickly here. So Alberto, can I bill for a diagnostic and procedural ultrasound code on the same date of service?
That's going to be a no. We cannot do that. So I think it's been very clear that you cannot do diagnostic and procedural ultrasound code on the same date of service. And this doesn't come from us. It actually comes from the NCCI, which if you go to the next slide, we'll show you what that is. And it's basically CMS, right? They developed this National Correct Coding Initiative, ideally to promote the correct coding and when to use which code and obviously eliminate improper coding. So this is not us telling you that. It's this NCCI group that you cannot do them at the same time.
Okay, but what if I do a diagnostic evaluation of two different body parts? I mean, is that okay?
That can be okay, but you have to be cautious, right? So the idea here is that you have to have a reason on why you're doing two separate diagnostic evaluations. And if you do that, you have to use this 59 modifier to make sure that you indicate that you did two distinct procedural services. And obviously, because they're two different services, you want to have two separate procedure notes for each body part, but you can do it. It can be done.
And of course, if it's bilateral, there's actually a -50 as opposed to a -59, right?
Correct.
And we'll cover that also. But what if I perform multiple injections? I mean, how can I bill for that?
It depends. I think we alluded to this a little bit earlier, and I think that this is where that 50 modifier comes into better play, and with using these joint injection codes, right? So let's say I'm going to perform a shoulder injection and a knee injection. So basically what we're going to do here is use 20611, right, to indicate major joint, but I want to use this 59 modifier to make sure that I indicated the fact that I did two separate injections, because those will get paid as two full codes, as opposed to, let's say you do bilateral knees, then you're only going to use one injection code, 20611, with the 50 modifier that indicates bilateral, and you will get paid one full and the other one about 50% for the second one.
Okay, now, what about like carpal tunnel? What about carpal tunnel, like where you have to use 76942?
Well, that you only get to bill for one unit of the 76942. So if you go to the next slide, this will tell you that essentially what you're getting, regardless of the number of needle placements, 76942 is just one global payment for as many needle placements as you want. Now, you can bill multiple or different injections. Let's say if you did a tendon sheath and a carpal tunnel, you're still only getting paid one ultrasound guidance, but you will get paid the code for the other two injections.
Right. And I think really what we're trying to get at here is that there are actual rules and regulations that have been in place in this case, 2017 for this specific edit, that actually states specifically what you can and can't do. So it's not things that we've made up or we found. You can actually go read about this. So, like, for example, the whole same date of service, don't report that. I mean, don't do that. But here's another thing. Some people have started saying, okay, well, I'll just bring people back on a different day to do my injection from my diagnosis code. That's fine if you've done that historically. If that's something that you do routinely in your clinic, no problem. But what they're looking at is they're looking for people that are trying to jank the system a bit. And so that's why they've actually included there, don't do this, please, unless it's something that you do routinely in your practice.
Right.
All right, let's do a couple of recording images. So primary recorded images, and Alberto kind of alluded to this earlier, is that it's really important that all diagnostic interventional ultrasound examinations are recorded and there's some way to reference it, to prove that you did it. Either print, tape, electric medium, and it should be kept in either the patient record or the archive. And it doesn't usually have to be submitted with a claim. Almost no one asks for that, but it has to be, basically accessible. It has to be available upon request. So that written report is super important to have in the patient record. It should be separate from the patient records like E&M file. However, it can be within it potentially if that's your routine, if it's a complete. And then another thing that's really important is that if you do declare a complete exam, if there's some element that you couldn't evaluate, you got to say so. You can't just blow it off. Otherwise, it becomes a limited. Even if you did like 98% of the exam, but don't state the last 2%, it's limited, not complete. Then, of course, if you do a procedure, like I do a lot of procedures in the OR, that can be included within my surgical note. It doesn't have to be separate from my surgical note, but you just have to make sure it's there that you did it and how you did it. Okay, let's do some case examples. Alberto, 72-year-old female, history of knee OA, returns for follow-up. She wants you to repeat her series of viscosupplementation. She notes, however, the pain's now over the patellar tendon. You examine her. You're kind of worried about the patellar tendon, so you want to ultrasound it. You don't see any damage. How are you going to bill this?
Well, what I'm going to do is first, because we're discussing a new problem and I'm going to do a new evaluation, I am going to bill for an E&M follow-up code. And then because I am doing a diagnostic ultrasound evaluation, I'm going to use the 25 modifier. I did a limited evaluation, so I'm going to use 76882. But because I can't bill for the injection, I'm actually going to have to bring that patient back for her injection series. And at those subsequent appointments, I'm only going to bill for the 20611.
Yeah, and the way I do it, of course, is that we have to get authorization for the Visco series. And so it's within the normal process for our clinic to say, sorry, we can't do your first shot today. We're going to have to bring you back. So it's not like we're doing it intentionally. Let's be clear. We're doing it because we have to get the authorizations to make sure it's all correct, because we weren't aware we were going to have to do that. That's something that she just said when she came in. So, it's within the normal of our practice, not something we just decided to do because we got paid more.
Right. Correct.
All right, another case. 54-year-old female, hand numbness, 3 months, no injury trauma, symptoms are worse in the first 3 digits, wakes her up at night, clinical suspicious for CTS. Ultrasound evaluation does reveal hypertrophy of the median nerve and entrapment. You decide to do a carpal tunnel and ultrasound on the same day because you did evaluate her and I did the shot. Now what do you do?
Well, same thing. Because you did an evaluation management, you're doing an E&M code. And because I'm doing a separate service, I got the 25 modifier. I did the 76942 needle guidance because it's not a joint. And then I'm going to bill for my carpal tunnel injection 20526.
What about that?
However, I am not going to bill for my diagnostic evaluation.
Yeah.
Because obviously we talked about you can't do them together.
Yeah. And I think what we're trying to basically tell people is don't just throw all the codes in and let them figure it out and you get what you get, because I think that's really not elegant and nice. It's better to know the rules, do it right, bill correctly. There's going to be less problems. Unfortunately, I've heard from some people that have gotten audited, and you just don't want to go through that. So as long as you keep everything clean, get good documentation, get the proper authorizations and denials, keep everything on board, medical justification, you're going to be good. And you're going to make the money back and you're going to be able to pay for this easily. Alberto, we wrote a paper, didn't we?
We did, and I can't believe it's been 2016 already. That means I was in my 30s. I'm now in my 40s, but that's okay. I think the point being that the good news is that even though this paper is from 2016, the rules, the codes, and everything we discuss in the paper has not overall changed. Obviously, the reimbursements might have changed, but I think the general guidelines, this serves as a really good guidance document on how to do the reimbursement coding.
And unfortunately, the journal that we had published in 6 years ago has no longer had the articles available. So if you want the articles, you can get them, download the PDF from my website, hirharmd.com. So feel free if you're interested at all. Oren, that's about it for us. Do you have any other questions for us?
Great. No, I want our participants to please use the Q&A on the bottom. There's already a lot of great questions in there that we'll get to before the top of the hour. We want to do a quick demo here. And so I've got the L15 set up here on a shoulder preset. And what I've done ahead of time, just to kind of highlight some of the features, is I can get the annotation and workflow in. And if you have a medical assistant or someone in the office, or this is someone you can easily do on your own, I often do it on my own, is I type in the name here of the patient, Alan Hirahara. I gave you a very generous date of birth. You like that? And then put in a kind of note here for maybe what I would be doing, subacromial injection. So this is something your admin could easily have preloaded when you walk into the room if that was something that you're doing in your office practice. And then I've got my L15 here. I've got my patient sort of in position. Let's say I know we're going to do a subacromial injection. So I'm kind of going on again as Dr. Hirahara guided us with the elbow back and in the injection plane, shoulder, contralateral shoulder to the hip. And there's my acromion. What do you think? Fair enough angle, fair enough access here, guys?
I think that's really, really good. And I think the key is you're showing that hyperechoic subbursal fat really nicely.
Right here. Yeah. So I'm just going to kind of dive my needle. I'm not going to put my model through that today. So he doesn't have any pathology, but I would be kind of coming in right in plane right there. And what I can do is I set up on the preset on this device where I can actually just click the button with my finger. And then I can record the screen now while I'm doing the injection. Say I want to do it again. I just hit the button again with my hand that's holding the probe, and it's firing off clips to the patient record while I'm doing the procedure. So I don't have to touch the iPad or anything. I just have my hand with the needle. It's really a quick, 15-second procedure ultimately. And as soon as I'm done, I can go back and I can even review the images here if I want. Here's the one. Okay. So if I wanted to do that, I could also annotate it if this was a diagnostic one. And I've also preloaded this one. I know I'm doing a lot of subacromial studies. So I can say here, I know I have the supraspinatus, the subacromial bursa, and the deltoid. I want to label all those. And with a quick touch of my finger, I can drop those on. There's my subacromial bursa, supraspinatus. Depending on what I needed to do, I could also freeze that, take an image, a picture to scan it also to the archive. And once I'm done with everything that I like, I can go back to the record. And I already have all my demographics and the exam done to the secure cloud, and away it goes. Archived, and now it's searchable through my Clarius cloud. If I need to retrieve it for some reason, either audit, insurance company wants it, or for documentation purposes, or there's other ways that I can now integrate it into the patient record, really makes it easy with just a couple touches.
Well, I think this goes to show how much ultrasound can just be a direct extension of your clinical exam, right? People think that it's going to take so much time to do, but it's literally plug and play. Would you agree?
I agree. I mean, I go to my shift. Maybe it's not applicable to all our webinar viewers today, but I work in a really busy ER, and I always just have the handheld probe on me because that's the easiest. I don't have to chase down the cart,
Yeah.
and I know I'm going to be scanning half the patients I'm going to be seeing, and I just turn it on as I walk in the room. And by the time we're talking and rapport is set up, I'm already ready to go. I even have my little mini gel bottle, and I'm going. So.
And then, are you using an iPhone or iPad?
Yeah.
What are you? How much visualization do you need?
So I use an iPhone because that's just, or a handheld, a smartphone, whatever. But personally, I have an iPhone, and that's just what I already have on me on my shift. So I don't really want to carry another thing. For me, being light and efficient to move around is a key importance. I think if I had an office set up, I would free up that hand with a tablet on a cart. And then just kind of have that ready so that, because you do need that hand for the needle. So you need one hand for the probe, one hand for the needle, and you need your screen. So with the iPhone, I'm doing procedures on my iPhone a lot, but I kind of need a little bit of space. So I often put the iPhone down somewhere to watch.
Sure. Make sure that it sits in.
Yeah, great. Well, Thanks for that, guys. We have a lot of great questions in the Q&A. I encourage you to keep filling them in and putting them in. We're going to hand it over to Janez, and then we'll get to the Q&A.
Fabulous. Thank you, Dr. Hirahara and Dr. Pinero, for all your insights for optimizing reimbursements. And thank you, Aran, for the fabulous live demonstration. It's always so exciting to see our new third generation Clarius HD3 in action. Before we open up the floor to live questions, here's a quick poll. We'd like to help everyone continue on their journey in bringing ultrasound guidance to their practice. So please do complete this poll if you'd like any additional information on our new third generation wireless ultrasound solutions. You can click on as many as apply. So if you'd like to get a quote or pricing, please select that option. You can opt to speak to one of our experts about the advantages of point of care ultrasound. You can book a call to discuss scanner features. You can book a live virtual demo with our clinical specialists, or you can opt to watch more tutorials. We have some fabulous tutorials with Dr. Hirahara that we make available to you as well. So please do select all that apply. While you complete the poll, I will take a minute to introduce you to our new third generation Clarius HD3 scanners. They're now 30% smaller and lighter with an integrated battery, and they deliver best-in-class wireless ultrasound for MSK diagnostics and interventional procedures, as you saw today, with easy-to-use app powered by artificial intelligence and connected to the cloud for convenient exam management and storage. Our Clarius linear scanners are specifically designed to effectively guide pain management injections with superior MSK and needle imaging, and they deliver several advantages. Clarius is unrivaled in near field and high resolution imaging in a handheld device. This best-in-class imaging is what you need for great tissue and needle visualization. As you saw today, you get clear view of nerves, vascular structures, other anatomy, and your needle for safe ultrasound-guided procedures. The secret lies in each scanner with 8 beamformers, 192 elements, and artificial intelligence that together deliver the image quality only found in traditional systems, but at a fraction of the cost. And with AI replacing complex knobs and buttons, it's as easy to use as your smartphone or tablet. Clarius is also wireless, freeing up space with zero footprint for ultra portability in a variety of settings, from the clinic to the field. Or the ER with Dr. Frankel. You get free movement with no more wires getting in the way and touching your sterile prep area. With no wires, Clarius is also so much easier to clean, disinfect, or fully encase in a sterile bag. Only Clarius delivers wireless scanners with an ecosystem that includes free apps for your iOS or Android devices for unlimited users. Available with our new membership, Clarius Cloud is available to easily capture, store, and manage unlimited exams and build reports from anywhere. Your membership includes in-app Clarius classroom videos with experts like Dr. Hirahara and onboarding with Clarius clinicians to build your ultrasound skills. And Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. We'll now close off this poll in 3, 2, 1. Thank you. If you ask for more information, we'll get back to you in the coming week. Just before we start our Q&A session, we'd like to also invite you to pre-register for our next webinar, Expert Ultrasound-Guided Blocks for Knee Surgery, IPAC, Genicular Nerve, and Abductor Canal Techniques. Guest speaker, Dr. Greg Hickman, is founder of BlockJocks.com, and he's the medical and anesthesia director at the Andrews Institute Ambulatory Surgery Center in Florida. Dr. Hickman has perfected his block techniques over the past 30 years, with the past 15 using ultrasound guidance. It's an opportunity to learn his expert ultrasound guided techniques for providing the best post-operative pain relief for patients undergoing knee surgery. Please complete this poll to register, and we'll send you a confirmation email in the coming days. I'll give you 5 more seconds to save your seat. 4, 3, 2, 1. Thank you. Now on to our live Q&A session. I'd like to welcome back Dr. Hirahara and Dr. Pinero to answer your questions. Please use the questions icon in the menu bar to ask your questions of our great clinicians. Dr. Frankel, I'll invite you to moderate, please.
Great, yeah, I will jump in. Thanks, Janez. So I'm just going to jump in, guys, and ask first, do I need to label my images in my diagnostic ultrasounds when I record them?
I don't think so. I mean, it's nice if you do so. It's not required. Really, what's most important really is if you have that written report. That's the most important thing really for documentation. It's very nice to label them. It's very nice to put labels on the images directly. I definitely think it's something that's very good to do because often, we'll switch back and forth between, medial, lateral and move it around based on the best way to see something. But it's not required from a billing point of view.
When you're securing your clip, it's really easy to kind of tap, at least on the Clarius device, and throw in your labels. You can even pre-do, if you do a lot of, say, subacromial injections, you want to show the deltoid, supraspinatus, maybe the bursa, and you can kind of throw on the labels really fast. Have any of you gotten pushback from insurance regarding knee injections, particularly with ultrasound? Someone has heard that insurance companies believe ultrasound is unnecessary for knees without some complicating reason like obesity.
No,
I have not. Never.
Okay.
And I would push back against them, and I would write them a letter.
Me too. Yeah.
And send them papers because honestly, that's reprehensible. That they should try to dictate how we do it appropriately for the patients.
I'm going to reframe this question a little bit. Who can do and build these CPT codes? Is there limitations on specialty? Is there limitations for mid-level providers, or do they have to use separate CPT codes?
No, I mean, my understanding is that the CPT codes are CPT codes. And so, for example, if you're a mid-level provider or working with another physician, you're using the same codes. There's no difference, really. I think, Alberto, have you heard anything else? That's what I understand.
No, I think maybe depending on the state, if the mid-level or uses it independently, then I think they might get a lesser reimbursement, but that's going to be for all codes, not just ultrasound. I think it might get like 85% unless they're doing it under supervision from the physician. But I think that's going to apply to every code, not just ultrasound.
This is a question probably for Hirahara. Do you and or can you use and bill for ultrasound prior or during surgery? And maybe you could speak to that.
Yeah, I saw that question. That's a really good one. From my point of view, what I like to do is I use actually the ultrasound during the surgery to help guide, because my problem is that, especially when you're doing the surgery, the structure might move away. Like if you're like I do all joints. So if you move the joint, the structure might go in a different spot. So pre-marking the skin about where things are, I find to be very unreliable. So I like to do things live. Like I very rarely will do where you mark the skin and all the 4 points and go to the center spot, or where you'll go out of plane. I do almost everything I do with ultrasound surgically in plane so that I can put my needle on the exact spot I want to go. Because often what I'm doing is I'm going to be drilling a hole. And so really for me, it's all about in surgical use to be absolutely sure I'm in the right spot. And doing it, unfortunately, if you do this, put a spot on the skin. If you put your needle in, there's a degree of freedom that you could miss based off how far away it is. Even if it's fairly superficial, you could still miss your spot sometimes. So I'm more hardcore about trying to use it in surgery to make sure I'm point specific.
Great. And I'm going to combine a couple of questions here. One is maybe the way to frame this is for other applications, say like dry needling or hydrodissections. Is that a 76942 code if you're using ultrasound?
Yes, it would be a 76942. Now, you also have, what I would do is I would check with your Medicare carrier and in your region, and they typically have a list of what injection codes you can pair with the 76942. So I think if you have a dry needling CPT code, you look and see if there's a pairing with 76942. If it's a hydrodissection of a tendon, I would maybe consider doing tendon injection, which is kind of the closest one. Or if you're doing a nerve injection, I would build basically a guidance with a nerve injection. And I don't think there's a hydrodissection code. I think you're just talking about what you're injecting around.
Okay, great. And I think we have time for one more question. It's a big one, so we might go over a minute. But it's a question that always comes up, and I think people want to know, how do they learn to do ultrasound-guided injections? And maybe to speak to that, how did you guys learn to integrate ultrasound? And if you could go back, how would you integrate it better for people maybe earlier on in their training?
Well, Alberto is easy. He came and did a fellowship with me. So that's a simple question. As far as I'm concerned, I'm older. And so, basically, you basically take courses. I actually, the way I did it was I actually brought an ultrasound machine home and said, hey, to my wife, can you get naked? It's might be a little cold. Sorry. And I just had the books out, and I went and got an an MRI disc that I would scroll through the different cuts and basically learn all the anatomy for the different levels and correlate it with what I saw in ultrasound. And then most importantly, anytime I got an MRI that had a positive outcome on a result, I would ask the patient, hey, I'm not charging you. Can I ultrasound your shoulder, your knee, so that I can prove to myself what I see? So I kind of learned over time. And then, of course, I see Dawn Buford's on the chat, and Dawn does a great job about doing some courses too. So, going to courses and learning how to do this from experts is really the key thing. And then just experience, getting practice and being comfortable. But I think the best thing is every patient comes in that has a positive finding on MRI, go find it yourself, prove it to you that you can see it on ultrasound, and then you'll learn over time to be comfortable with what you can do.
I agree with everything, except the fellowship part.
Useless for you, I know, but that was a fellow. What can I do?
Great. Okay, well, there's a few unanswered questions here, which we will certainly follow up with people, but I want to respect people's time. We're over the top of the hour. I will hand it back to Janez to take us home here.
Wow, what a great session. Thank you so much, Dr. Hirahara and Dr. Pinero. We have reached the top of the hour. If we didn't get to your question, we'll follow up by email in the coming week. You will all receive a copy of the slides in PDF format and the webinar recording as well. We'd like to again thank our doctors for all their insights. A big thank you for joining us today. We hope to see you again on August 24th for our upcoming webinar with guest speaker, Dr. Greg Hickman. In the meantime, have a wonderful rest of your day and keep scanning.
Thanks, everybody.